Good morning. This is Rochelle Seeger. I'm with the Foundation for a Healthy Kentucky, and I'm so glad you've joined us here today for our Health for a Change webinar, Kentucky Health and COVID-19 Response. The Foundation for a Healthy Kentucky's mission is to address the unmet health needs of Kentuckians, and we do that by developing and influencing policy, improving access to care, reducing health risks and disparities, and promoting health equity. The Foundation for a Healthy Kentucky values integrity, respect, effectiveness, leadership, policy equity, and collaboration. And collaboration is what this training series that we called Health for a Change is all about. Health for a Change was begun in 2011 to support the work of health advocates across Kentucky. The photo here on your screen is some of the many partners, community health advocates, and people in Kentucky who are working to improve health. And it has been a great honor to work with them on the Health for a Change training series. The Foundation's website, healthy-ky.org, has a lot of information about our organization, and on the Events tab, you can find the archives of the Health for a Change webinars and also the upcoming events in our training series. healthy-ky.org. Again, my name is Rochelle Seeger. I'm very honored to be working here at the Foundation as a Community Health Research Officer on the Foundation's Data Initiative. I want to take this moment to thank all of the people from Kentucky Health Department, from the state and local health departments across Kentucky who I know who have been working extremely hard over the past year on our COVID-19 response across Kentucky. So to all of you who are working so hard, thank you for all of your work to help us, and I'm glad you're here today on this webinar. A reminder to everyone, a recording of the webinar and a PDF of today's slides will be posted at the Foundation's website later today or tomorrow, and I'll send you an email with that information as soon as they're posted. Also later this afternoon, I will send you an email with a link to a post-event survey. I know many of you on this call are data lovers just like myself. I would love it if you would take just a few minutes to give me feedback about what you thought about today's webinar, how we can improve, and send ideas for future events. If you're logged into the web portion of things, you'll also see a portion of your screen where you can chat in questions, and those questions will come directly to our presenters. We should have a few moments on today's webinar this morning to answer your questions. Now, I'm very pleased to turn over the call to our first presenter, Vivian Lassie-Bibbs, MPH. Vivian is Director and Epidemiologist at Kentucky Department for Public Health, Office of Health Equity, and she's also the Chair of the Foundation for a Healthy Kentucky Board of Directors. Welcome, Vivian.
Good morning, everyone. Thank you for joining us this morning. I'm excited about the presentation that you're about to hear and see. Many times we hear and see presentations and don't really know how they apply to real-time work, but I'm happy to say if you stick with us this morning, at the end of our presentation, we have Lieutenant Colonel Garrett with the National Guard, who's actually going to show how they've used this tool and applied it to the work currently going on with the COVID-19 pandemic recovery and response. So looking forward to hearing that. Next slide, please. My co-presenter is Rhiannon Simon, who is working on the tool specifically with the Environmental Public Health Tracking Network, and you'll hear more from her in just a moment. I really want to start off with the potential uses for the CCVI map. Many times we do health equity work or we do public health, population health work in communities, and we really are kind of taking a blanket approach to many of the things that we do, meaning we're not very specific and precise on whether we really are reaching the populations that need to be reached. The CCVI tool gives us a way to be precise down to the census tract level and really be able to target resources, staffing, funding to the communities that have the greatest unmet need. And that's the beauty of the tool. And we haven't had that before when we've talked about health equity and talking about social determinants of health. Where do people not have access to fresh foods? Where do people have transportation issues? What is the housing situation like? What is population density like? And what are some of those other social determinants, even upstream, that are impacting communities? And I'm sure you've heard about things such as redlining and the physical and built environment in which communities live that all impact long-term health. So we've been able to use this tool to be able to refine how we talk about health equity. And it's really been a great tool since the pandemic, because we really have had to reach out to our most vulnerable populations to ensure that they have access to the vaccine and that they're able to uptake that vaccine based on what their physical and built environment may or may not be providing for them. Next slide. So health equity, we're a proud partner with the Environmental Public Health Tracking Network at the Kentucky Department of Public Health. Our tools can support the work that we do. We always use a data-driven health equity approach. We always support resource allocation decisions, and we want to make sure that we're doing due diligence with the resources that have been provided to us. We want to make sure, like I said, that we're prioritizing populations with the greatest unmet need. We always want to show how place and environment impact health. And we also want to address some of those root causes that are upstream, but also remembering those midstream social determinants of health as we address public health issues. So health equity should be in everyone's public health practice. It should be in everyone's toolkit, so to speak. So I'm hoping that you will see the application of this tool moving through the presentation. And when you leave today, you can say, wow, that's a way that I can apply this tool to the health equity work and be able to really measure an impact moving forward. So at this time, I'm going to turn it over to Rhiannon Simon with the Environmental Public Health Tracking Network to take you through the CCVI tool. Rhiannon?
Thank you, Vivian. Like Vivian said, my name is Rhiannon Simon. I'm with the Environmental Public Health Tracking Program, and I'm going to take you through the nuts and bolts of the tool and kind of the history behind it. As you can see on your screen now, this is a screenshot of our public-facing website, envirohealthlink.org. And the tool we're talking about can be found on our website on the right-hand side under the Interactive Map section. And I'm going to talk a little bit about another tool that kind of helped get us to the CCVI, the COVID-19 Community Vulnerability Index, and that's the Social Vulnerability Index. We started that one first before the pandemic, and that's also one of the areas where we started with our partnership with the Office of Health Equity. And the COVID-19 Community Vulnerability Index is actually kind of built off of the Social Vulnerability Index. So that's where we'll start. The Social Vulnerability Index is a tool created by the CDC to measure community vulnerability across the U.S. And you can find those variables on their website, but we kind of took their data and adapted it to a Kentucky-specific interactive map that you can see here that is also available on our website. There's information on the left-hand side that tells you a little bit about it and how it can be used. And our CCVI is built along the same line. So if you know how to use one of those interactive maps, you know how to use the other one. So that is a screenshot of the CDC's SBI website, and the website link is posted there so you know how to get to it. And really, social vulnerability refers to the resilience of communities when they're confronted by external stressors. And the SVI is an index score, and it's comprised of 15 measures from the American Community Survey data. And the SVI groups those into 4 themes: socioeconomic, household composition and disability, minority status and language, and housing and transportation. So here's another screenshot of the tool that we're going to be focusing mostly on today, which is the COVID-19 Community Vulnerability Index. You can see it looks very similar to the map that I showed you earlier. And there's, like I said, it's built off of some of those same themes, and so that's kind of the underlying reason behind that. This map is supposed to focus very specifically on one external stressor, and that is the COVID-19 pandemic. So this map measures, and this index measures how resilient a community is to COVID-19. So it is also an index score, and it's comprised of those 15 measures and 4 themes that we previously talked about on the SBI, plus 10 additional variables and 2 additional themes. Those 2 themes are epidemiologic factors and healthcare system factors. And these index scores take all of this data and they rank them using percentiles. And a percentile rank is the percentage of tracts at or below a particular rank score. And the maps operate at 2 different geographic scales, at census tracts or at counties, and then ranks all those measures on a score from 0, which is least vulnerable, to 1, which is most vulnerable. And each of these maps has a legend that contains this kind of gray box right here on the right-hand side that can help you read the map as you look at them. And a score is calculated for each of those themes that we talked about, as well as an overall vulnerability ranking. And importantly, for our tools on our website, these maps show the rankings for within the state. If you go to the national websites that support the data, the CDC for the SBI and Sergo Foundation for the Ccvi, that shows national score rankings. But the tool that we created based off of that information shows information for within the state. I want to take a moment and talk a little bit about sub-county geographies. We get a lot of questions about why our tools use census tracts instead of zip codes. And there's a couple of good reasons for this. Census tracts are small, relatively permanent subdivisions of a county. Zip codes change a little bit more often, and they don't nest within county lines. So that can be really difficult when we're looking at providing information to counties and at the local level. And the SBI, all of the information, all the measures are available at the sub-county level. The Ccvi, that's not always possible because of those additional themes and the nature of the data within those additional themes. But the majority of the information from the Ccvi is still available at the sub-county level. So I want to get a little bit into the structure of the interactive map. It's based off of the index score. The structure of the score is the structure of the interactive map. And this is just a schematic to show you the 4 original themes of the SBI and how they roll up into the COVID-19 Community Vulnerability Index. That first tab of the map is going to be your overall vulnerability score map. And then as you tab over to the right, you'll see maps for each of the individual themes as well. And for the SBI, there are maps available for the individual measures as well. Now, the part that makes the Ccvi so special is these 2 additional themes. And these themes are made up of many, many different factors, individual measures. For the epidemiological measures, there are measures including cardiovascular conditions, respiratory conditions, information on the immunocompromised, obesity, diabetes, population density, and influenza and pneumonia death rates. And then for healthcare system factors, there are multiple measures, and they organize them into 3 buckets. Measures that indicate health system capacity, health system strength, and health system preparedness. Now, for these 2 additional themes, there are not individual maps for the individual measures, and that has to do with the nature of the data and the geographic level that we have that data at. And this is a schematic putting all of that information together that should kind of help you get a mind map of the way that the interactive maps are structured. So let's return to looking at the maps themselves now that we have that under our belt. Here's that landing page again. On the right-hand side, you see the legend that will help you read it, as well as on the left-hand side, some information about where the data is coming from and where the original data was found, and links to the original organization that compiled all of that data. The next tab over is the Socioeconomic Theme. That contains measures on poverty, unemployment, income, and education. The next tab over is that Household Composition and Disability Theme. This tab includes information on the elderly, children, those living with a disability, and single-parent households. And this screenshot shows what it looks like when you scroll in far enough to get that sub-county view. You can scroll in using your mouse or these buttons here on the screen. This is your minority status and language theme. It is comprised of two measures, percent of minority in the geographic area and those speaking limited English speakers. And I just wanted to take a moment to point out that the importance of that sub-county feature, the ability to get some of this information at the sub-county level. We've got two different screenshots here. The one on the left-hand side shows some of our larger urban areas and kind of the way that looks at the sub-county area. This is Louisville, this is Lexington over here. But also on the right-hand side, we show the eastern side of the state and how if you zoom in at a sub-county level, you can see a little bit more diversity than you probably would have expected in eastern Kentucky, kind of showing that, you know, data at different geographic levels can really help us know a little bit more about communities and know that certain parts of the state are not a monolith. This is the Housing and Transportation tab. It contains data on large apartment buildings, mobile homes, crowding, homes with no vehicle present or available, and group quarters. And this screenshot shows that if you select any of these geographic areas, you can get this pop-up box that includes the scores and the measures for what's available in that geographic area. It also shows you, if you see down here at the bottom, we've got the Kentucky CCVI score, which is its ranking within the state, and then also the CCVI score right here, which is the national score. So this is all relative information, so different measures can be used for different purposes and can tell you a little bit more about the geographic area that you're investigating. So this is the next tab over, the next theme, which is your epidemiologic theme. And I think this one will be really useful to a lot of folks. It shows kind of a composite score of different health factors that might influence vulnerability to COVID-19 for a geographic area. And this theme includes information on folks with high blood pressure, high cholesterol, folks diagnosed with a stroke. The respiratory factors include those who have asthma, those who have been diagnosed with COPD, emphysema and chronic bronchitis, and information on adults who smoke cigarettes. The immunocompromised bucket includes information on cancer incidence as well as those living with an HIV diagnosis. And then the rest of the health information in this theme includes obesity, diabetes, population density, and influenza and pneumonia deaths. And here's a look at that same theme score, just zoomed in to look at the sub-county area. And this is our final theme score. This is our healthcare system factors theme, and information included in this theme include hospital beds per 100,000, ICU beds per 100,000, and epidemiologist jobs in the area. There's also information on admission rates for preventable conditions, health spending per capita, total public health emergency preparedness funding per capita, health labs per 100,000, and emergency services per 100,000. And I did want to take a minute to talk a little bit about the geo-precision of some of the measures on this theme. A lot of this information is not available at the sub-county level. Some of this information is only available at the state level or the hospital referral region, and so this will probably be the least informative at the sub-county level. You can still get a theme score for the sub-county level, though, but it will be the least geo-precise of the themes, but still useful, and still useful for the roll-up into the overall Ccvi score as well. So that is an overview of the way that the interactive map works and where the information is and where it comes from. And as Vivian pointed out before, we see a lot of potential uses for this interactive map. We think it could be useful to you to find information to help with decision making during for resource allocation for the COVID-19 response. We think it will help with reaching vulnerable and minority populations for outreach and communications, figuring out where those populations are within your jurisdiction, and maybe helping to influence some of those work plans to reach those populations, and just being able to do any of the work that you're currently doing with an eye towards health equity. It also gives us a good chance to get some of that sub-county data that we don't always have available to us. And so that's one of the really valuable things that this can do for us is give us a chance to look at some of this information at a geo-precision level lower than the county. There are some other potential uses as well, any other general program planning and evaluation. If you have an intervention that you wanted to try out, you could target specific populations. And it could provide information for program justification and work plans, and it could potentially be used for grant writing as well for future plans. So having said all that, I would like to turn it back over to Vivian.
Next slide, please. So I'm hoping that you can appreciate the robustness of this tool and the capacity that it gives us to really look granular. We've never been able to get this detail when we're talking about populations. We've never been able to get census tract level precision and how important that is to do health equity work. Because we need to understand where those disparate health conditions occur. Where are they occurring at the highest levels? Where are communities being impacted the most? And as epidemiologists, if the data don't reflect that, then we don't recognize that as being valid, and we don't do further investigation. So we have data now to show how these health disparities, health inequities, how these social determinants are distributed by geography. And I think that's important because not all of our communities are monolithic. They're not all homogeneous. When you get down to that precise a level, we see where pockets are and how those pockets may be impacted by some of those social determinants that we've described earlier in the presentation. And we need to understand how they're interacting and how they're interacting with the community itself, and what we can do to intervene. So the SVI and the CCVI are those data tools that will help us do that. So I'm hoping that you can be as excited about this as I am, to be able to say now we have something to really look at specific populations within communities and really focus our energy, time, efforts, resources, funding to address some of their unmet health needs. Next slide. So before I let Lieutenant Colonel Garrett kind of do the real world example application of using this tool, there's some things I just want to leave you with, some thoughts before she comes on and shares their work. Is, the Kentucky Department for Public Health is moving beyond just looking at health disparity data. Data is great, but we've got to look at how that data and how that disparity gap, what's driving it? What are some of those predictors? What are some of those social indicators that are causing that disparity? And that's where I think the SBI and the CCVI come in, to really look at those buckets of housing, of transportation, of unemployment, of education, income, housing density, disability status, minority status, English is not the first language. All of those are crucial to me as a health equity expert in addressing and improving the health of those communities. Without that information, I'm just addressing the problem. I'm not looking upstream to see what's causing that, right? I'm putting a Band-Aid on. And I think all of us in public health are tired of just putting the Band-Aid on. I think we need to think about, okay, how can we prevent this downstream? What's happening upstream that really we need to start having the hard conversations about? And I think this data will help us leverage those conversations. This gives us tools now to go to those that make decisions as to how they should be addressing some of the issues that these communities are facing. So tools like this will help us do that. We've got to move beyond our programmatic professional academic silos. And I think the COVID-19 pandemic has done that. It's required us to collaborate, to share expertise, because the COVID-19 pandemic has shown us just how complex health equity issues can be as it relates to chronic diseases that have made people at most more vulnerable than others, made populations more vulnerable than others, and how we've really had to bring multiple partners in to address not only those conditions, but people's access, their physical and built environment, and a bunch of other social factors that have come into play. So we've got to overcome the mindset that health equity is just a public health issue. It's everybody's issue. Health equity and equity in general and social justice should be on everybody's plate, to think about how they can better communities in which they live, in which they serve, in which they practice. So my thought that I want to leave with you is to put the question on you today as to how you would use a tool like this and how you would begin to have conversations based on the usefulness of this tool and addressing some of the inequities you see around the Commonwealth and in your local communities. So that's going to be my parting thought with you. I'd like to bring on Lieutenant Colonel Garrett now, and she can introduce herself and all her credentials and her background. And she's going to give you a practical application of this tool and how it's helped her and her team move forward in the pandemic response. Lieutenant Colonel Garrett.
Thank you, Vivian. Good morning. As Vivian said, my name is Lieutenant Colonel Jessica Garrett. I've been in the Army for 24 years now, both as enlisted and as an officer. My primary focus as an officer has been as a logistics officer and a chemical officer. I've had a little bit more experience over the past year with the pandemic response than maybe I had ever thought I would. My last command, we actually set up the alternate care site in the Louisville Convention Center and manned that fortunately was not used, but that's where I got a first taste for, okay, here's how we're going to treat patients as they come in if needed. That transitioned, and I thought I was done, but I got a call saying, hey, maybe you can go help Department of Public Health with a little bit of vaccine distribution, and that was where I thought we were going to work. My team came on board in January, and as we started looking at the data across the state, we realized very quickly that we needed to develop some profiles at the county level to understand who lived in those communities, what the populations were, what they were made of, their demographics. And we were introduced to the SBI, but not necessarily the tool, and this tool using the Ccvi. With the SBI only, we had to add in comorbidities, and it just added a layer of maybe having data that wasn't as accurate when we added both SBI and then had to use comorbidities. Rhiannon introduced us to this tool, the Ccvi tool she's shown you, and said, hey, this might help. As we got further into this mission, looking at where vaccine is available and who it's reaching, we quickly saw, as most people on the team did, that those counties that have a high SBI, that have high rates of comorbidities, whose poverty levels are very, very low, whose ability to access transportation or have their own transportation are low. We realized that, okay, maybe we're not approaching this the right way. So when we looked at the Ccvi and the maps included in it, we were able to not only take the metrics that we used to show which counties were truly the most vulnerable, but then at a granular level, look to see where those individuals lived within those counties and use different layers to see where vaccine's available, how far away is it from those individuals, what is needed to get vaccine to those individuals who are most vulnerable in order to ensure equitable distribution across the state. For us, we looked at the Ccvi. We looked at age, so over 60 or over 65. We looked at their poverty levels. We looked at race, and we looked at transportation. Because for us, even if you saturate the state with vaccine in pharmacies, in Walmarts, if you have hospitals that are doing outreaches as well, it doesn't matter if that vaccine is not going to a county, into an area where 25% of the population doesn't have a vehicle, and unless it's within walking distance, they can't get to it. Or if they have such high comorbidities that they don't have the ability to leave their home to go get the vaccine. So then what are we doing, and how are we reaching out to them? And then when you layer in race as well, you can see very clearly in some of these underserved counties that where we are distributing vaccine versus where those individuals live is a huge gap. And bridging that gap is something that our team started to use the Ccvi tool to do. We were able to drill down into those specifics, transportation, poverty, and race, to see exactly where those individuals are in the county. I say exactly, and I know I'm not getting an address, but we can see where they're shaded in within the county, so that as we do that, we can layer where vaccine's been distributed to include the number of individuals by age and race who have already received the vaccine in that county. And in doing so, we are almost able to go in with the precision of a scalpel, for lack of a better term, and pull out who we need to reach within that county to ensure that we are truly reaching out and distributing as equitably as possible. Having said that, without the Ccvi, there's no way we would have gotten down into the county level as granularly as we did. Are there any questions for me regarding how we approached it?
Rochelle, I think we're going to turn it back over to you if there's any questions that have come in that we're not seeing, or some that have come to you ahead of time, or if there's any questions we can answer, all three of us.
Yes, thanks so much. Lieutenant Colonel Garrett, reflecting back on the past few months where you've been working on the distribution of vaccines, as we move forward, is there additional information that you think would be helpful to you to do that planning? I know this is a great start, but what additional information might you have needed?
The only additional information we really needed was being able to see at the county level by address who had received the vaccine, and that's something that I'm not sure this tool would have provided. That's something we were able to pull from Tiberius, which is another system we use. Overlaying those two things is really what's been critical to seeing what a county truly looks like with regards to vaccine distribution and then uptake within that county. So from the CCVI perspective, it provided us really what we needed in order to both make decisions on who needs to be reached the most, but also where they reside, and then how to use that with the county leadership so that they are working with us on using resources within that county to get the vaccine to them. So for us, it was a great tool. I'm not sure of anything right now that, man, I could go back and say, oh, if only we had this. No, when we saw it, it was eye-opening, and we were able to use the data from it to work with us in making recommendations. So it was great.
And I just want to add to that, if I could. I think the local health department and the local communities have really found this to be invaluable to them because to be able to really target and focus within sub areas of their county, to really say, okay, if this particular demographic or this particular audience is not, according to our records, having access to the vaccine or able to do to uptake the vaccine in the way that it's being presented, then conversations happen at the local level. Dots are being able to be connected to say, okay, this has been identified, but what do we do about it? And I think that's the beauty of what's happening in local communities is they're having to talk to each other and have conversations with organizations, with churches, with folks that don't look like them or communities they may not have been in, to start having a conversation and start coming together to make sure that everybody in that community feels valued and everybody in that community is getting equitable access to the vaccine like everyone else is across the state. So I think that's the beauty of this, is that not only the use of the tool, but the application of this tool in local communities and conversations that are a result of, right? So I think when Lieutenant Colonel Garrett goes to communities and talks to local communities and says, this is what we're seeing, this is a tool that we've used, how can we help? Is there anything that we can do to help you connect the dots here and to make sure that everybody in your community, right, has equitable access to this vaccine? And that's what, to me, makes my job rewarding, is to see that taking place. So,
Vivian is absolutely correct, and it's one thing for a county to know, I know what my county looks like, but to have the metrics behind it to support it, it just really enables them and empowers them to make an even bigger difference with how we respond with vaccine equity, the current mission.
Thanks. And this is a question for Rhiannon. You can start, and then Vivian, if you have additional ideas. A reminder to our audience, we still have some time for your questions, so please continue to send those in via the chat. This question from our audience member: who are the primary users of these data tools? I know you mentioned the health department. Who's not using them that should be using them? Vivian?
That's a good question, and I think that's a question Rhiannon and I had when we first started having conversations around the SVI, because we've been having these conversations. The tool has been around a while, and we've been having this conversation on how to get that knowledge out to local communities, how to empower communities to use the tool, and we've even pre-COVID, had done some work with local health departments on program leads, on epidemiologists that are staffed there, on making sure that even their community partners who have data capabilities could have access to this tool. This tool can be accessed by anyone. It's not just a public health, state health department tool. So we really wanted to get the message out to everyone who has data capabilities or who has someone that can help them leverage the information garnered from the tool, to begin to talk to communities, to begin to talk to city planners, to be talking to, those within the chamber, within their local chamber, to be able to utilize and leverage this data in multiple ways with multiple audiences. So those are the folks that we want to use this data. The foundation can use this data, right? And the work that we do, the work that you do, Rochelle, to strengthen the data that you already captured. And this could be an additional tool within your toolbox that you could use to look at maybe some of the areas across the state where the foundation needs to place more emphasis as we do our work moving forward, right? So I think this is not just for public health professionals. I think it's for anyone who wants to be able to start having a conversation around the inequities within communities, right? So Rhiannon may have a different answer, but that's mine.
I would 100% agree with that. I mean, it's very important to us that this kind of information is publicly available. Anyone can access it. It's available on our website. With that comes some challenges, though, because there might be people using this tool that we don't know about, which is great in many ways. We want it to be used, but also that means that we may be, the loop isn't closed. We may not know about it because they may not have asked for assistance with it, which is perfectly fine. But if people are using it and would like to tell us their use stories, we'd love to hear that. We could lift that up. And also, if people wanted to start using it and are maybe unsure of where to go forward with it, they can always contact us. And I will put my email up here on the screen so that we can provide them any assistance that they might need, and maybe quickly zone in on those areas that they might have questions about, or just be able to help them use it quickly with very little time involved.
Thanks, Rhiannon. And here's a great question from an audience member. Can you prepare a custom report for my service area?
We don't necessarily prepare custom reports, but what we could do is show you really quickly how to get all the information that pertains to your area. One of the neat things about the interactive tool is that you can select one of those geographic areas, and all those different measures will pop up. And we could help them interpret it very, very quickly as well.
Thanks. Another audience question. Where can I find information on poverty or low education on the CCVI that would help me address issues where those factors are risk factors?
Yeah, so that information can be found on the Socioeconomic Theme. And so this is a good example of if a particular area has some questions, very specific questions that they want to ask, they can use the tool to zone in on some measures. That would be on the second tab, the second theme of the interactive map, where they could find that specific information.
And another audience member asks, do you have plans to develop indexes for other threats or other health issues in Kentucky?
Not necessarily at this time, and I think it's important to remember that we didn't develop these indexes. The SCI is a CDC tool. They've validated those measures in that index, and the CCVI was created by Sergo Ventures, Sergo Foundation, in collaboration with the CDC in order to address this very specific threat. What we did was contact those organizations and tell them what we plan to do, and adapted that information for use within Kentucky as opposed to the national scale.
The
Thanks.
tool really was designed as a preparedness tool. So it really was designed to show you, where are your most resilient communities or your less resilient communities. So that the tool has been adapted to look at different things now, just like the SVI was created, and we've kind of used the health equity lens to kind of walk you through that tool. This CCVI was developed as a different way to use the SVI tool to look at the pandemic. So I don't know whether there'll be an additional application or use. Let's hope it's not for another pandemic. But I can see the usefulness now of people kind of putting their head around other, maybe not health issues, but I could see them using it for maybe other ways to think about inequities from maybe a cost benefit or a health economic impact position. So I see there could be multiple uses for it. I think what we're going to go back to maybe is, and my friends in other states who run offices of health equity or minority health are going back to the SVI and overlaying specific chronic diseases that are impacting their state. For example, I know Ohio, and I have a good friend there who's done it, and Rhiannon has seen his conversions analysis, where he takes the SVI tool and he overlays specific comorbidities related to the health disparities that are ranked within his state, which may look different than surrounding states. So he's using the SVI tool in that way to really look at which chronic diseases or infectious diseases are impacting hard-hit communities in Ohio, right? Where are those counties in Ohio that have the highest amount of diabetes, obesity, heart disease? If he's using those three disease entities, then he's overlaying that information onto the SBI analysis, right, for his state at the census tract level, and then he's using that, he's leveraging that data with not only the state but local partners to say, here, I've identified where this triangle, this triad of diseases is impacting communities of color the most in Ohio. This is where we need to be placing resources and dollars. And so I think
I have one more audience question. This one is, you recommend moving beyond our silos. Can you give an example? Where should I start in the community? Moving beyond the silos. Rhiannon or Vivian, do you want to answer?
I can start with that one. I think that might be more of a Vivian question, but for example, Kentucky Tracking and the Office of Health Equity has been working together for several years now, and just discussing issues that we share an interest in and think that we can work together to really contribute to. At a local level, I think that tools like this can help spark conversations too. You could use the tool to start talking about some issues that, maybe you wouldn't traditionally talk to people in different areas of your workplace or different organizations within the community, and talk about maybe some things that impact health but maybe aren't considered traditionally within a healthcare or a public health scope. So, you could use this as a tool to start that conversation, but also to start looking at some of those upstream issues that Vivian keeps talking about, things that influence health, but maybe do so in a way that we don't maybe always see because of the length of time between the issue and how it impacts health, and just not being traditionally defined as within a health or a public health care realm.
And I apologize, my phone died. It just went away. The call dropped, so I'm sorry if I missed anything, but it sounds like Rhiannon was answering a question well, so. But I'm back.
Well, I would love to hear your thoughts too. Maybe Rochelle, could you repeat the question for Vivian?
I'm glad to. Vivian, this question was about moving beyond our silos. Can you give an example, or where can people start thinking about moving beyond their silos in this work?
Sure, I can address that internally, and I think I can address that externally as well, meaning outside of your local health department. So I'll use the example of how we've had to come out of our silos internally within the Department for Public Health to address the COVID-19 pandemic. So my office, the Office of Health Equity, was immediately involved. The Environmental Public Health Tracking Network was immediately involved. The immunization branch, the communications team, the disaster preparedness team. These are folks that don't usually talk every day, right? These are folks that operate within our little worlds, and if something happens and information needs to be garnered from that group, you go to that individual and you get the information you need and you walk away. The pandemic has revealed the need for collaboration, that we have to talk to each other, that each of us brings something to the table, right? Equity needs to be at the table to assure equitable vaccine access, immunization to make sure allocation and distribution, right? Our disaster preparedness folks to make sure that we're able to get the vaccine where it needs to be, that logistically things are falling into place. The Environmental Public Health Tracking Network to make sure that we're using the latest and greatest data and the tools. So we've all had to come out of our silos and talk about how we can collaborate to fight this pandemic. Same thing can happen externally outside of your local health department or state health department when you have to talk to folks that you don't normally talk to, right? Those are conversations with folks that you may not routinely talk to. You know they're in your county. You know they maybe exist. You know maybe the work that they do, but you haven't had to sit down to the table with them, pull up a chair and have a conversation about how you can address something together. And I think that's what the pandemic has revealed to us. If there is a good side to the pandemic, it's forced us to talk to each other. It's forced us to collaborate. It's forced us to have hard conversations. It's forced us to look at our communities with a different lens. It's forced us to really be present. And by that I mean not doing things traditionally like we always have done, but to think of creative ways, new ways of tackling a situation. So, that's one thing that I can say that COVID-19 has shown us. This is what we should have been doing all along, and this is what you can create if you do it, right? So let's not go back to the way we used to. Let's not go back to our silos and live there. But if we can do this in the pandemic, we ought to be able to do this daily in our programming areas for population health that we normally do, right? We ought to be able to come out of those silos and talk about new ways to address some of those issues that we've been dealing with for the last 10 years. Obesity, diabetes, heart disease, stroke, cancer, and the list goes on. So I did want to say I thought of other ways that this, as I was looking at questions, other ways the tool could be used. And, if anybody's going through accreditation with Public Health Accreditation Board, the CCVI and the SVI can be particularly strong tools as you're doing your community health assessment, where you need to be talking to populations, where you need to make sure that you're reaching out. And also as we go through public health transformation, we're having to do more with less. We're streamlining. This would be a good way to be able to make sure that dollars and resources are going where they need to.
Sounds like maybe Vivian's call got dropped again, but Rhiannon, quickly, the last question on our call here, what information from the CCVI could help us decide where to locate events for the public?
Yeah, so you could find information that might help with that on the Housing and Transportation tab. I think a lot of folks are particularly interested in areas that have a high percentage of homes that don't have access to a vehicle. Also, disability information. Those areas with folks living with a disability might also influence where you might locate an event in a community. And as always, I think that information, really heavy, like quantitative information, is always best used when paired with, knowledge from your own local community. So I think that it's important to remember that as well. Like, having the quantitative data is really important, but also, like, we understand that you who live in your local community also has important information that might help you decide where to locate events. So I think using those two things together is really important as well.
Thank you, Rhiannon. You see Rhiannon Simon's email address there. Everyone can get in touch with her with your additional questions on the CCVI and the data website. Also, thank you to Vivian Lassie-Bibbs for sharing her time with us, and Lieutenant Colonel Garrett for sharing this real-world example with us here today. Also, I'd like to invite everyone on the call to join us this Friday for another Health for a Change webinar at 1 p.m. COVID-19 and Health Equity, Views from Eastern Kentucky. So we'll have leaders from Kentucky Department for Public Health speaking specifically about vaccine distribution data and what the current status of that is. We'll also welcome Samantha Brown, community health worker from Kentucky Home Place, who works in that region, and Chief Medical Officer at Appalachian Regional Healthcare, Dr. Maria Branham. So please join us this Friday. A reminder that the slides and recording of today's webinar will all be available on the Foundation's website, healthy-ky.org, under the Events tab. Again, sincere thanks to each of you for joining us today, and thank you for our presenters. Rochelle Seeger here. I'm honored to work at the Foundation for a Healthy Kentucky as our Community Health Research Officer. Thank you for joining us. I hope you have a great day. This concludes today's webinar.